Good afternoon, everybody, and welcome to this HCC session of the GECO meetings. First of all, let me just thank again the Gastro Foundation and Project ECHO of the University of New Mexico. As you know, these sessions are held every Wednesday. And for today, we've received 43 registrations, apart from 11 sub-Saharan African countries. We also have attendees from Australia and from Saudi Arabia, so all very welcome. It's really a pleasure for me to introduce the panel of today. So Dr. Wanga Sobnach, that will give us a case presentation of a patient pregnant with an HCC, and that's what the discussion is going to be about. We also have Dr. Osman, the gynecologist that was involved in the care of this patient, that kindly joined us for the meeting, and then Dr. Wanga Sobnach, one of our fellows, will give us an overview of the management of HCC in pregnancy, but he's also going to talk about some related other tumors that you may be confronted with in pregnant women. So thank you very much, and Wanga, I think we can get started.
Thank you, Prof. All right, as Prof has already introduced me, I'm Dr. Wanga Sobnach, one of the fellows in the Division of Hepatobiliary Unit in Fortescue Hospital. I'm just going to present a quick case for us of the day. We were presented with a 29-year-old female who was married, mother of mother of four. She's otherwise well with no known illnesses, with a good performance score of 1. She presented with an abdominal mass of increasing size in the last 3 months. However, the mass was noted from about 5 months back. She otherwise was well, not acutely ill looking, with a gravid abdomen with this big epigastric mass, very tense abdominal distension. She otherwise has been taking oral contraceptive pill between pregnancies, and the ultrasound was done to interrogate the mass, which just showed a large mixed echogenicity mass. Couldn't really define where the mass was coming from. Just on the background, a patient is known with hepatitis, chronic Hep B. The hepatitis B surface antigens were positive, and the core antibodies were also positive. And we also did tumor markers to interrogate it. The alpha fetoprotein was 148. We do know that the alpha fetoprotein does go up in pregnancy. Otherwise, all other tumor markers were normal. We did LFTs, which just showed a mixed picture. Otherwise, no obstructive jaundice. As a collectively, because we're suspecting that this patient might be having HCC, and possible in the background of chronic Hep B infection. So we did a child Q, which we scored at 6 points, and also the MELD 9 points. So further to assess the patient, we did an MRI. The MRI showed a large mass, predominantly on the left lobe of the liver, segment 2 and 3. As you can see on the imaging, with a bit of central hyperintensing scar. So we sort of set in our X-ray meeting to decide initially what this was, to decide on the way forward. And we went on to do a contraceptive MRI using gadolinium. So this is just to move to the next slide. So if you look in the arterial phase of the scan, you can appreciate that there's a hyper-enhancing, but yeah, heterogeneously enhancing mass, enhancing capsule on the arterial phase. And you can see that there are some other satellite lesions around the vicinity of segment 4 and 5. That's also, sorry about the imaging, there was a bit of movement artifacts when we did the scan. And to move on to the portovenous phase, you can appreciate that there's a significant washout on this scan. You can see also those other satellite lesions as well, quite a significant washout as well, and on that portovenous phase. And you can see, if you just look at the visualized portion as well, there are some lesions on the lungs, which would be highly suggestive of metastatic disease as well. Yeah, so I'm just gonna end it at that. So we did a chest X-ray as well. Sorry, chest X-ray to try to see if there was any obvious mets as suspected by the MRI. The chest X-ray doesn't really show much, but if you look very carefully, there are some nodules that would maybe suggest, but not really big to draw any conclusions on this. But perhaps one looking at this, considering also the MRI, maybe one can say these are probably metastatic disease. They're quite small. Yeah.
Okay, so thank you very much, Wanga. So I think there are a number of issues that we maybe can discuss. The first, Dr. Osman, Aisha, this patient is 24 weeks pregnant at this stage. The wish of the mother was to continue with the pregnancy and to deliver the child. How long should we try to or to what gestation do we need this pregnancy to advance before a cesarean section would be possible?
Oh, thank you, Doctor. So from our side in this setting, public hospital, Grooterschuur, Cape Town, South Africa, we need babies around about 800 grams, 27 weeks for good outcomes. And this is just the bare minimum that is still, they still face a number of risks in the neonatal ICU, in that early gestational, early postnatal period, as well as the risk of sepsis postpartum. So bare minimum, we would be trying to aim for the 28-week mark, 27 weeks, 800 grams at least, and then try and get steroids on board to improve neonatal outcomes. For the best outcomes, we would try and push the pregnancy as close to 34 weeks as possible. This gives us a better take-home rate in terms of babies not requiring an ICU admission and then discharge straight to families. However, like most maternal fetal discussions, it's a balance between how much can the mother tolerate, how far can we get safely, and what the impact of the growing pregnancy with this large mass, what's the middle way between the two.
Yeah, so if we're going to put a time on this, to which week do you think we should get in this patient?
If all stays the same and the mother can tolerate the pregnancy with good growth and development, good Dopplers, 34. But otherwise, every week after 28 is a bonus.
All right. And what would trigger an earlier cesarean section before 34 weeks? So when would the decision be made to proceed, even if the risk is higher?
So any deterioration for the mother in where the delivery will improve the maternal outcome would trigger delivery. And should delivery improve her therapeutic options postpartum, then yes, delivery should be triggered. And then I suppose if we're looking at the size of this mass and we are thinking that this is a cesarean section, then yes, if the woman went into spontaneous labor, then that's going to trigger trigger the semi-elective delivery rather than allowing the rupture of the mass, which is going to be, which is the other side of a vaginal delivery.
Yes. Well, thanks for that. I can maybe just talk about the workup in this patient. It was discussed, it was decided to do an MRI. And as you could see, contrast was given. Dr. Sobnach, I think you had discussions with the radiologist on which contrast one can use, because obviously for the characterization of the HCC, ideally we do need contrast. The options here would be gadolinium or Primavist. Can you just tell us how they came to the decision to give gadolinium?
There's actually very little data for this. The discussion I had with Prof. Benningfield initially was that we would give a very low dose of Primavist to get as good as possible a picture of this tumor. But at the end of it, they ended up using GAD. And it was also a low dose and only to see what was in the liver and nothing else. Primavist, as I think we've discussed numerous times, crosses the blood-brain barrier. So there's always a concern that it might have some adverse events on the fetus. There was recently a massive study that looked at whether GAD is safe in pregnant patients, and they looked at a total cohort of 4 million people. I think the estimated number for pregnant patients in that cohort was 60,000. And there were very few adverse events associated with GAD, and those were early labor and fetal loss, but there was an association between a poor outcome or an adverse, may I say, an adverse fetal outcome when GAD was used. But like Aisha is saying, I think one of the most important things is risk versus benefit here. The margins are so thin already, and whatever decision we're making here is really to try and determine what this tumor is about and how long we can prolong this pregnancy.
Oh, thanks for that. So before we're going to talk about the management of this patient, let's just look at the other concerns here. I see Professor Spearman and Professor Sondrup are in the meeting as well. So the patient is hepatitis B, has got hepatitis B. I assume that she was on some form of treatment. Wendy or Mark, how should we look at that aspect in this patient? I don't know. I don't think we showed the counts, the viral load in this, but I suppose that was known. How would we address this?
Yeah, I mean, Ed, it's Mark here. The viral load in the patient, unsurprisingly, being E antigen negative, was quite low. There's about, if I recall, barely log 3. And in any event, for what it was worth, she was initiated on oral antiviral therapy. There's probably no real data that antiviral therapy will influence the course of the tumor at this stage. But what it does provide is in patients with impaired function or with advanced fibrosis, it certainly does get you virally negative and improves overall liver function in anticipation of a potential intervention. Now, in her, of course, her baseline liver function was not significantly impaired, but as a broad, sort of brush stroke, what antiviral therapy offers you is then just stabilization of the actual liver disease, as I said, in anticipation of an intervention. So she was initiated on oral antiviral therapy. We just chose lamivudine. It's effective in patients with low viral loads, and she's been on it since her transfer to our hospital.
Okay, thanks very much, Mark, for that. Just before we carry on, please, if there are any questions or any comments, this is obviously an unusual and quite a sad case. Please post them, raise your hand, or even just write a comment if you've got a question. So
Sorry,
yes, Winnie.
Hi. So, I mean, the one thing, if one was going for a resection, is obviously not the case here. I mean, use of tenofovir has certainly been shown to decrease the risk of recurrence post-resection. So that's something, if one was going for resection, would be quite important. And then obviously just to remember there's a baby as well. So one wants to prevent the risk of acquisition of hepatitis B to the baby. So if the viral loads were very high, greater than 200,000, you definitely would start tenofovir during the, well, as soon as you diagnose a hepatitis B. So one just needs to remember that. And in this baby, I think also to remember the baby needs a birth dose vaccine, which is not been implemented universally yet.
Yeah. Thanks for that, Wendy. So if we just put there was a quick hand up, but I think it's gone again. I didn't catch it. Karan, was it you?
Yes, Prof, it was me. Thanks.
Hi.
Hi. I just had two quick questions. I know for this patient, again, it won't impact much on management, but on the imaging, was there any features of liver cirrhosis or fibrosis or advanced liver disease in the normal liver? I must say I couldn't see much. The outline looked quite regular on the right side of the liver. I didn't see any ascites or anything in the abdomen. No real features of portal hypertension, but I'm just wondering if when the images were looked at in more detail, if that was picked up or not. And then for Sanju, just in terms of the contrast choice in pregnancy, did it have any difference what trimester the contrast was given in, or is it just a blanket kind of poor outcomes with gadolinium, or not poor, but sorry, increased risk of early labor and things like that with gadolinium? Because as far as I know, a lot of things in the second trimester are usually generally safer, but I might be wrong. So maybe we can just shed a bit of light on that, please. Thanks.
So I think just in terms of the cirrhosis, Karan, I think we regard it as it doesn't look as if there's cirrhosis. It's very difficult to assess whether there's an enlarged caudate or an enlarged left liver, because the whole left liver is tumor. But as Wanga showed, the patient had very well preserved liver function. So if there was cirrhosis, she would have been in a child PUA category. The other question, Sanju, I don't know if you had anything on that. Whether I think it's really about the developing child, and the development. I think altogether is at risk, regardless of at which time you give it. I don't know, Dr. Osman, is there anything from your side where you would allow a CT with contrast in one trimester that you wouldn't in another?
So I think it's a little bit more the way Sanjay explained it. It's about the risk-benefit ratio. I think the first trimester is still the highest risk in terms of fetal abnormalities specific, but then later trimesters, you're looking at things like IUGR or growth restriction, which then comes into play, and then the stillbirth. But yes, it wouldn't be excluded in the later trimesters if its benefit, as in this case was, that it helps make the diagnosis and plan the management.
Okay, thanks so much. So if we just put the pregnancy aside for the time being, and we regard this patient as just a non-pregnant patient that is presented with a tumor to that extent, massive tumor in the liver, well-preserved liver function. But unfortunately, we can maybe just go to the next slide, Wanga. We did decide to do a CT that you can maybe take us through or just run through while I talk. So it was decided to do a CT scan just to see what the extent of the liver metastases were. And you can see here that this patient has got quite extensive liver metastases, small lesions everywhere in the liver. So we've got a situation of a patient clearly with a very big primary, with lung metastases, and under normal circumstances. I don't know, Mark, if you want to weigh in on that. I know we are very clearly transplantation and resection is not on, but and we wouldn't have offered this patient TACE either, or
I mean, Ed, I'm not sure if that is directed to me, but I mean, our practice at Critical Care would be in this situation, even though the patient has a good performance status, would normally be to offer palliative or best supportive care. We don't really have access in the state sector to any antiviral, any chemotherapy or any of the newer agents like or even sorafenib. So we really wouldn't be able. We would not normally treat this patient oncologically. Yeah, but I mean, don't want to jump to the next step. But this patient really wanted to get to the stage where she can deliver the baby. So that did come into our decision making.
So I mean that's right. So under normal circumstances, we don't have access to sort of new generation drugs. So this patient would have had a best supportive care. So the problem here is that we've got a growing fetus, and I think Mark, if I remember correct, we had a look at the alpha fetoprotein that increased dramatically, and there was concern that this tumor is growing faster. We didn't want to repeat imaging, and we're not going to do that, but that there's concern that there's going to be sort of competition between the tumor and the fetus for space in the abdomen. And then we were considering measures where we could slow down the growth of the tumor. Also, the increase in size it has got other implications, so that there's a higher risk for tumor necrosis. That may be a problem, but more importantly, that we get a spontaneous bleed in the tumor, or worst case scenario, that we get a rupture of the tumor. In terms of pregnancy, I'm just thinking if one had access to the newer generation post-sorafenib drugs, was there anything there that one could have considered, if we had access to it, that could be used in pregnancy or not? It was Mark or Wendy. I was actually thinking about Mark.
Oh,
yeah.
Sorry, I wasn't sure if it was Mark B or Mark S.
That question is too difficult for me, Mark.
Wendy, I mean, what do you think? I mean, I suppose in reality she has extensive metastatic disease, and one would have to consider whether she's a candidate for error for any systemic therapies. I suppose in reality, sans the baby, lenvatinib would be a reasonable option to consider, although she's got very extensive disease. All is going to be just about controlling growth of the tumor. Atezolizumab and bevacizumab has really become the first go-to therapy from a systemic point of view in terms of its objective response rates. But again, it's about accessibility. But I just think one needs to understand this is very extensive disease that has to see them. I think one has to consider what the benefits one is really going to gain.
Yeah, I mean, I don't think there's any data looking at those agents during pregnancy. So, I mean, I think one would be quite reluctant to do it while she's still pregnant. I think if one had access to the dual therapy, I think certainly this would be something that she's otherwise very well. I mean, her baseline is good that one would consider it, but we unfortunately don't have access to. I don't think sorafenib would have any role here. So we'll be looking at the combination therapies.
Yeah, so I think I'm just going to sort of move on a little bit quicker. So what we did is we had very long discussions about doing anything to try to contain the growth of the tumor, and we decided to do transarterial therapy. So in other words, TAE, transarterial embolization. Doxorubicin, you're not advised to give that during pregnancy. So we opted for just a bland embolization. And the patient was subsequently tolerated that pretty well and was subsequently discharged from hospital, if I understand it correct, Dr. Osman, and is being followed up and trying to see how far we can get her into a pregnancy.
That's correct. So we'll see her on a weekly basis in terms of symptom control and see how far we can get.
Okay, I can't see any questions or hands up at this stage. So, sorry, Wendy, you've got yours up.
I just think the other thing to remember that these patients are much more likely to have the paraneoplastic problems. I'm not sure whether we mentioned the risk of hypoglycemia, which can be quite difficult to control. And then they can also get, because of this extremely vascular rapid growth, these microangiopathic hemolytic anemias and profound thrombocytopenias. So they seem to be more aggressive in pregnancy, these extrahepatic manifestations.
Okay, thank you very much for that. So if no more questions, Sanju, thank you. We're looking forward to your talk on a little bit of a review of how we should manage these patients.
Prof, may I just ask a question?
Sure.
Suppose, maybe not to preempt Sanju's discussion, but suppose this tumor was localized to the left lobe and there was no metastatic disease, and this was something resectable with a good Child-Pugh score for this patient. Obviously, the approach would have been different, because now we're thinking about a curative resection, keeping in mind that we need to carry forward the pregnancy as far as possible. Would you still embolize, do a bland embolization, try and control the tumor growth, get the pregnancy, and then proceed to resect after delivery? Or how do you think we would have approached it then?
Yeah, so we haven't really discussed that, and I think Sanju is going to maybe address that. This patient had an alpha-fetoprotein of 3,000, and under normal circumstances, we certainly would have, or probably have considered to test the biology with a TACE. So one can argue that you should do a TAE there too. I mean, at that stage, it's not a risk for the baby. And now you're dealing with a situation where there's potential curative treatment for the mother, and you want to keep the pregnancy. And I think that's sort of a little bit more complicated discussion. I think let's go through Sanju's talk, and if it's not answered, we can maybe spend the last few minutes address that in the light of what he said, if that's okay with you, Karan.
Yes, of course, that's fine, thanks.
Okay, Sanju, I think you have to unmute and go.
Yeah, thank you very much for the opportunity for talking in this forum. So what I've done is I've kind of summarized all the liver lesions that pregnant patients tend to get, and I've looked at their management, and then I've spent half of the talk looking at focusing on HCC in pregnancy. So liver masses in pregnancy are extremely rare. And the current data is mainly limited to case reports and small series in the literature. Hepatic masses associated with pregnancy do present a massive challenge in terms of making a diagnosis and more specifically when it comes to treating those lesions. And the masses can obviously be infectious, benign, or malignant. A lot of the data that I've got is mainly from this article. There are very few reviews that have looked at liver lesions in pregnancy. In fact, there are only 3 of them in the literature from 1954 onwards. So this is an interesting article. So anybody later on can download this and read it. I found it to be extremely helpful. So what are the common lesions we see? Hepatic lesions we see in pregnant patients. We see liver cell adenomas, and that's 26 cases currently reported in the literature. FNH, 37 cases. Hemangiomas, 20s. And HCCs, about 33 cases reported in the literature. The reassuring fact is that most lesions that are seen during pregnancy within the liver are benign. Most commonly we'll see an hemangioma, a liver cell adenoma, an FNH, hematoma, that's less often, an angiomyolipoma, or lymphangiomatosis. Hemangiomas in pregnancy, this is the most common benign liver tumor seen in a gravid patient. Symptomatic patients can present with vomiting, epigastric pain, radiating to the back, difficulty eating, and most often awareness of a mass in the abdomen. They can also present with a Kasabach-Merritt syndrome, where the patients have quite dramatic thrombocytopenia and hypofibrinogenemia. Only 5% of symptomatic patients are at risk of rupture. Estrogen plays a role in the development of hemangiomas and the growth of these lesions. And the affected women tend to be multiparous and tend to present with quite large lesions. There's only one report of a ruptured hemangioma currently in the literature. And there's no difference in risk of rupture between pregnant and non-pregnant women. And obviously this data is based on not large series, I must say. So what's the management? They should be managed conservatively mostly. Lesions less than 10 centimeters have quite a benign course. Indications for intervention would include worsening symptoms, very rapid growth, if the patient has a Kasabach-Merritt syndrome, or if there's catastrophic rupture from an intraperitoneal bleed. And the treatment then is surgical enucleation. Rarely a resection is required. And there's a case of embolization performed in one case report in the literature. I must note here the recommendation is that these patients can have a vaginal delivery. FNH in pregnancy, the majority are asymptomatic again. The size ranges from 2 to 10.5 centimeters. They can sometimes present with right upper quadrant pain and the sensation of a mass in the abdomen. There are no reports of rupture during pregnancy. Management, generally managed conservatively, and you're managed expectantly during the pregnancy. Obviously, symptomatic or very rapidly enlarging lesions may warrant resection, and a vaginal delivery is acceptable again. Liver cell adenomas, what we call hepatic adenomas. The presentation of liver cell adenomas is unfortunately often catastrophic. They're generally large, 6.5 to 19 centimeters in large. There are about 26 cases in the literature, and 16 of them presented with rupture. The most often will present in the third trimester when there's the highest level of estrogen during the pregnancy, and they will present with right upper quadrant pain, epigastric pain radiating to the back or right shoulder, along with shock if the amount of bleeding is dramatic. The management, lesions less than 5 centimeters can be managed conservatively. If the lesions are more than 5 centimeters, they should be resected. In case of rupture, the maternal mortality is 44% and the fetal mortality is 38%. So this is something to bear in mind. A third of ruptures will happen postpartum. Many will still advocate vaginal delivery, although this is very controversial in the literature. So this is just a brief diagnostic algorithm. If you have a mass in pregnancy, your first port of call will be to do an ultrasound. If it's a cystic lesion, you can manage that on its own merits. If it's a solid lesion, then we proceed with an MRI. And depending on what the lesion potentially is, further directed investigations will be performed as shown in this diagram. And that's pretty much just a shorter version of this. So what about HCC in pregnancy? Hepatocellular cancer in pregnancy is very rare. If you look at cancers in pregnancy themselves, they are a rare event. There was a 7-year study conducted by Potter and colleagues that looked at 11,087 pregnancies, and the incidence of a malignancy happening was 9.2 per 10,000 pregnancies. Also, HCC pregnancy is extremely rare. There are less than 100 cases in the current literature. The literature is limited to case reports and case series. The biggest case series are 4 to 5 patients within the published reports. And there's one huge review that looked at 46 retrospective cases from various reports published in the literature and 4 from a single center. So why is HCC rare in pregnant women? Well, there are a number of postulates. The one is that the incidence of HCC intrinsically is lower in women than men. Therefore, pregnant women are less likely to have that kind of lesion. HCC is rare in people of reproductive age. And liver cirrhosis is associated with infertility. But I have to point out that only advanced liver cirrhosis is associated with infertility. And the interesting point is that a significant portion of HCC cases seen in sub-Saharan Africa are actually non-cirrhotic. So there are still some controversial issues, just like this topic. The role of contraceptives in the development of HCC in pregnancy is highly debatable. In massive case series, the risk is small, and it's only relevant to the use of contraceptives in patients who have been using them for many, many years. HCC risk during pregnancy increases with parity. If you have one child, so if you're P1, you're 2.1 times more likely to get HCC. And if you're P4, you're 3.5 times more likely to get an HCC. So cancer itself is quite aggressive in pregnancy. And the reason for that is hormonal. So HCG, estrogen, and placental lactogen are present in large amounts during pregnancy. They promote growth and reproduction of cancer cells, and they may aggravate the aggressiveness of these HCCs seen in these patients. There are some other suggested mechanisms. It's been suggested that there's an excessive inflammatory cancers present in pregnant patients. Tumors themselves are intrinsically more aggressive during pregnancy, and the relative youth of pregnant patients favors tumor growth. And the role of estrogen itself is quite interesting. It accelerates mitosis of hepatocytes. It furthers the development of hypervascularity in tumors. It is associated with the production of hydroxyl-free radicals that is associated with further mutations. It decreases humoral immunity that leads patients to be more susceptible to tumorigenesis. And it's also been shown to reactivate hepatitis B. And there's also some further interesting immunological explanations. There is an inherent state of non-specific maternal immunosuppression during pregnancy. The fetus itself is regarded as a natural allograft, and this non-rejection mechanism in malignancy, in the malignancy-pregnancy complex then prevails. And this makes the tumor more acceptable to the allogenic host, who is the mother in this case. And it's also been shown in some animal models, actually very early work in the 1960s, published in Nature, that show that humoral and cell-mediated immunosuppression has been observed in pregnant rodent models. So why the diagnostic delay? Why do these patients present late? First of all, probably the most logical thing is that the physiological symptoms of pregnancy are quite similar to HCC. Fatigue, nausea, vomiting, that could well be attributed to a pregnancy itself. Then there's some practical issues. A palpable liver mass is less evident in a gravid patient. And very often the diagnosis of HCC is made in a non-gravid abdomen after delivery of the child. So one must start with some baseline investigations. We would do a full blood count, assess the kidney function, the LFTs including an albumin, do an INR, do a hepatitis screen, and do an HIV test. MSAFP here is maternal serum alpha-fetoprotein. We do them routinely for our suspected HCC patients. But I must say in pregnancy, this is obviously something quite debatable. We would do them routinely between 16 and 18 weeks of pregnancy here as a screening tool for Down syndrome and neural tube defects. The normal range seen is 10 to 614 nanograms per mil during pregnancy, and this will rise up till the 32nd week of pregnancy. At delivery, it then starts to decline slowly, and the expected range postpartum is 50 to 100. Most authors have suggested that a maternal serum alpha-fetoprotein of more than 30%, of more than 30,000, is very supportive of HCC. But it's important to note that maternal serum alpha-fetoprotein can also be elevated due to maternal weight. It is elevated in some very specific ethnic groups, and it is elevated in diabetes, and specifically maternal diabetes. And the other important thing is we must be very cognizant of our setup in sub-Saharan Africa. We often see patients with very dramatic, large HCCs in non-cirrhotic livers with normal AFPs, and that are well known to be associated with poorer outcomes. And this has also been well documented in the North American literature and observed in the African American population. So imaging and abdominal ultrasound is always easily available at most of the hospitals in the province. There's no radiation, therefore it is safe in pregnancy. It will definitely tell you whether the lesion is solid or cystic. It will tell you whether the patient has got some of the features of portal hypertension. And to a certain extent, it can tell you whether there's gross cirrhosis or a completely normal liver. I think to say if there's an intermediate level of cirrhosis, obviously a bit more difficult, but I think it can point you in the right direction. A CT scan is not recommended. There's obviously the inherent risk to radiation. It can be used in some very selected cases, in which case a shield is used to protect the fetus in the uterus. I would say that MRI is the gold standard in pregnancy. The use of contrast is still very controversial, and the data is conflicting depending on what report you read. I think this is a topic for another seminar, but I think that here one must be quite pragmatic in their approach with the use of a focused MRI with very limited contrast, like we have done in this case. So in terms of the first trimester, maternal survival takes precedence. Delaying treatment until 28 weeks is often futile and is associated with poor maternal outcomes and fetal outcomes. And the recommendation is to terminate pregnancy and proceed with curative care where possible. This is quite, I think most authors are quite adamant about this in the literature. I know that we have adopted a different approach in our patient, but if you look at my last slide, I will tell you why that is the case. In the second and third trimester, some have performed hepatic resections for HCC in the second trimester and deem it safe for the fetus and the mother. Others have advocated that you must do a cesarean section and a hepatic resection in the third trimester at the same time. But what I think is important here is that all treatment strategies should be discussed in an MDT conference, and even if it means that they should be rediscussed on numerous occasions. There are also some other modalities. There's radiofrequency ablation. Obviously, not all patients are for a resection. This has been described as a form of treatment during the first trimester, and it is unfortunately limited to 1 or 2 case reports. TACE is not an option. Doxorubicin is teratogenic. But transarterial embolization, bland embolization, is definitely a viable treatment option. It can be a bridge to surgery, but whether there is a lot of data to support this my answer would obviously be no, because this has really been reported only in 1 or 2 case reports. I just want to finish up with this massive experience with this group in South Korea that have questioned whether HCC is more aggressive in pregnant patients. So if we look at what they found here, obviously the higher the parity, the more likely you were to have an HCC. There were also some other interesting facts. In this cohort, it was quite similar to what we see in South Africa. Patients had non-cirrhotic disease, and they were Hep B surface antigen positive. What I want to point out is on the last blue arrow, if you look at the fetal outcome. So what they did is they summarized the whole world literature, and they went and compiled all the case reports that were before 95 and after 1995 till I think 2001. And then they compiled that data together, and they found that the fetal outcome, so the chance of the fetus being alive, so having a successful delivery before 1995, was in the order of 52.2%, and after 1995 was 65%. So it means you still lose about half of these pregnancies. But what's also really sad and worrying is that if you look at the long-term survival rate of these mothers, the 6-month survival rate is 76%. At 3 years, you're down to 28%. If you look before 1995, at 2 years already, they have no survivors. So the prognosis in this patient is obviously quite guarded. And this is the Kaplan-Meier curve, which obviously says it all, where the mortality is quite significant postpartum over the weeks. So I've put together this algorithm. It is not based on massive evidence, but I think it is quite a reasonable thing to do. Once you confirm the diagnosis of HCC through a combination of modalities, you can then make a decision based on the in which trimester the patient is. If it is a first trimester, your recommendation should be to do a termination of pregnancy and proceed with definitive care if it is possible. If definitive care is not possible, then you should have some disease control strategies that could include RFA, other forms of ablation, a transarterial embolization. And then you can try and delay if the patient qualifies for definitive surgery up to the second trimester. If that is still not possible, then you might as well just carry on with the pregnancy and try and deliver the baby and then address the HCC postpartum. If you in the second trimester, you can go for definitive care, so resection. That's been advocated by many of the authors. And in the third trimester as well, you can go actually just deliver the baby and go for what you think would be the appropriate care for the HCC. My conclusions are not very scientific, but I think they are reasonable. HCC in pregnancy remains a very complex issue. I think you need to MDT these patients as much as possible. You need to include an obstetrician, a gynecologist, and a pediatrician, especially later on during the pregnancy if you manage to get there. Just remember, you might have a very careful plan for the patient that you have thought through the night. That's exactly what happened to me, but the patient might have other plans. They might tell you that they want to carry on with this pregnancy, and they will be absolutely adamant about it. So one must respect patient autonomy. And the last thing is to be pragmatic. I think these patients do not read the textbook. One can't really say, I know the recommendation is that in the first trimester, you must terminate the pregnancy. But I think if the patient has other wishes and they've made other plans, as I said, one should work around those and be pragmatic. I think that's where I'm going to stop. I'm happy to take questions if there are any.
Thanks, Andrew. That was a very comprehensive talk. Appreciate it. I think you answered Karan's question towards the end there. Yeah. So you know, I think if you had a resectable HCC in the second trimester, it would make sense to go ahead and resect it. You know, as has been mentioned, you're going to weigh the risks to the mother and weigh the risks to the pregnancy. But I think, you know, the risk of a HCC rapidly increasing in size as you get further in the pregnancy, if it's resectable in the second trimester, in most cases, I think you would probably proceed with resection. And as you said, in the first trimester, termination probably would be best from a survival perspective for the mother, but you would have to take into account what her wishes are, and whether that, and if she didn't want to have a termination, whether that really would be practical to, you know, would it be practical to try and proceed with the pregnancy. There is one other comment that I had. You mentioned that one of the reasons for low HCC is that there's not a lot of HCC in patients of reproductive age. I think that is probably true in the West, but it's probably not true in Africa. But a bit like the, you know, we have lots of cancers in non-cirrhotic livers in Africa as well. And I think in Africa there may be more patients, pregnant patients, than are, you know, it's the same thing. There's just no literature on it.
I agree with you, Mark.
Yeah. I'm not sure if there's any questions from anyone or comments. So another thing that I find a little bit tricky is the management of adenomas in pregnancy, and especially someone who's diagnosed with an adenoma, let's say that's 4 centimeters, so that, you know, not quite big enough to resect, but is quite keen to fall pregnant. And I had a brief chat with Ed. You know, I think what you'd probably do in that patient is observe it very closely with ultrasound or whatever during pregnancy, and if it rapidly increased in size, then you might be forced to resect it in the second trimester. If it was obviously a big adenoma going into the pregnancy, then you would resect it. I don't know if you agree with that, Ed.
come on. Yeah. Thanks, Mark. Yeah, I think so. That's also sort of a very difficult topic, because we know that they can bleed quite spectacularly, and I think if the risk is really high and you're somewhere in the second semester and it's not a really big liver resection that you need to do, one should probably in those patients also consider a surgical option. But clearly you don't want to do massive liver surgery with the risk of blood loss and a complicated course afterwards. So I think it's often a very difficult decision. I don't think there's, and maybe Sanju, you can chip in here, I don't think there's a lot of evidence supporting a bland embolization of the arterial supply of the adenoma. But that's maybe something that I would look at. Sorry, I just had to run out to theatre for a few minutes in the middle of the session, so I may have missed something here.
No.
So if it comes to sort of a embolization of an artery here during for a large adenoma, Sanju, was there anything forthcoming?
I think I might be wrong, but I think there was, I mean, these were just mainly large case reports. I think there was one case where they did actually do an embolization for a patient that bled out, but that eventually proceeded to a resection.
You know, one of the things about adenomas that's not really in the guidelines is they're very like stuck on the size of the adenoma, but not much is often said about where it is. You know, like a 5 centimeter adenoma that's in segment 2-3 is different to a 5 centimeter adenoma that's sitting, you know, in segment, you know, like 8, you know, right in the middle of the liver. And I think, you know, you're going to be much happier to resect a segment 2-3 lesion than something right in the middle of the liver. So that's something that's also not always taken into account. All right, if there's not any other questions, I think that we're going to end the session. I'd just like to thank all the speakers, and thank you to the ECHO team, University of New Mexico, and the ECHO India team. There's a feedback form available in the chat, and recordings will be available on the Gastro Foundation website. Thank you to the Gastro Foundation, and thanks to the sponsors. And next week is inflammatory bowel disease, management and challenges in complicated inflammatory bowel disease. Thank you very much, everyone.
Thanks a lot.
Thanks a lot. Thank you.
Thank you.